Minimal incision foot and ankle surgery, MIS or MIFIS being another name. We can see on the left a traditional surgical incision and on the right a minimally invasive or minimal incision type surgery incision. To give you a bit of an idea of what I'm working with, on the left there is our minimal incision burr, not too dissimilar to what we're using in the clinic as a nail burr. Obviously a few more precautions around the sterility, but a lot of these burrs are quite fine, only 2 or 3 millimetre or 1.5 to 2 millimetre in diameter. On the right, we've got my Dream, which is a fluoroscopy machine, an X-ray machine, intraoperative imaging. And this is, the machine that makes everything a lot more seeable and visible. To give you a bit of a background on minimal incision foot and ankle surgery, has been practiced since 1940 and where bunions were undertaken. At that stage, they were mainly an ostectomy or a shaving of the bump. But over the last 2 to 3 decades, and even 4 or 5, we've had a lot more research and fine-tuning into how we undertake these procedures. Currently, we have research indicating that it's at least equal outcomes to open surgery. And again, this depends on what we call, so in my hands, we generally get quite good outcomes, and there's a bit of a learning curve to that as well. We do usually require fluoroscopy or intraoperative imaging, which is that X-ray, but it doesn't always need to be utilised either. Generally, we like to think that we know our anatomy quite well and we know what structures we're targeting there, but it's always nice to have X-ray to ensure that we're doing the right thing. And we don't always require fixation or hardware, and I'll go through a few of those in a little bit too. And it can be undertaken by a local anaesthetic, which is really enabling for patients, because that means that we can have patients that are potentially at higher risk undertaking these procedures that they may not have otherwise been able to. But in the right situations, of course, we may need to have patients under GA as well. Procedures that I'm currently undertaking in the rooms are tenotomies of the flexor tendons of the toes, neurolysis for the Morton's neuroma, and we do that through a deep transverse metatarsal ligament release, and also plantar fascial releases. And now these are all safe procedures to do within the rooms, and are done, quite quickly and safely. With the use of fluoroscopy, we also have the option to undertake further procedures, including bony osseous procedures, such as hammertoes, bunions, osteophytes, such as implantar heel spurs, as well as flat foot correction via the extraosseous tarsal tunnel stabilization. And I'll go into that a little bit further under the heel pain. But I'm not in the position where I've got that appropriate procedures room just yet. So watch this space over the coming year or so, and hopefully I'll be able to start looking at these options as well. In doing that, it's going to save patients money. It's going to increase the potential ability for patients to recover quicker with less concerns due to the local anaesthetic, and will just allow for a smoother transition from your rooms to my rooms to look at an opinion, to surgery, and then the recovery around that too.